Ron, John, thank you. It's a true honor to be presenting this. This has been a huge, huge passion of mine since 1998, when we became interested in this version of sort of sexual health. I have no disclosures. Since 1998, I've been involved in the study, diagnosis, and treatment of individuals with a vulva. And just recently, this September in Rio, I was at a session with Faisal Yafi, and he's taken one of my fellows on in his faculty, and I asked him what it's like to now have some faculty member doing FSD. And here's what he said: you don't know what you're missing until you have a provider in your department specializing in FSD. And I just want to keep reminding you, for all your, whoever here is in that position, to take on FSD. I think it's the next level of all of this. And what Helen has done is integrating into the sessions women's sexual health. It looks like it flows and fits in so easily. So I think that's the way to go. So from the view of 10,000 feet, Brantley Scott's surgery in 1973 sort of changed a field called male sexual dysfunction into really eliminating it as a psychologic-only field into a biologic field. Now, he only thought the implant was useful for radical prostatectomy people, but you see how it expanded. And 25 years later, take 25 years for FSD, which was exclusively psychologic in 1998, to turn into the equivalent with a biopsychosocial sort of condition. So on the bottom, here, I'll mark here. On the bottom here, the AUA, again, through the American Foundation of Urologic Diseases, held a nomenclature and classification committee, which then brought FSD into a biopsychosocial world. We had disorders of orgasm that could be biologic, disorders of desire, disorders of pain, etc., whereas previously everything was psychological. So the pink things are the nomenclature things that happened along this 25-year passage. The ICSM, which Hossein, wherever Hossein is, the first one that included women, because the other ones included ED only, was in 2004. And then ISWISH with Menopause Society put together the new naming of vulvovaginal atrophy to genital urinary syndrome menopause. And then ISWISH did its own classification system, again, expanding nomenclature, allowing for more biopsychosocial. So the blue things are the 8 things that I'm going to talk about along the pathway of these 25 years. But the true take-home message is that ISWISH, this amazing organization that really is the society for the study, diagnosis, treatment of women's sexual health issues, along with nomenclature things, have changed the field dramatically. And that's the ISWISH major slide. Here's the things I'm going to take you through in the next bunches of minutes as the medical treatment breakthroughs and the surgical treatment breakthroughs. So the first ever drug that the FDA ever approved where we could apply it to women was this drug called ospemifene. It's a SERM, and it had action on both androgen and estrogen receptors. And I had the privilege of looking at thousands of photographs sent to me in a blinded way through a secret internet system where we took photos before and after the treatment. So if this was the look of the vulva and vestibule by photography prior, and that's the way it looked after, you could see how healthy it looked before and after. Now we had a sham arm, before and after didn't change at all, and before and after didn't change at all. And these were thousands of photographs, and it's all published in the literature. And then Sue and I and others in our department took on ospemifene, not through photographs taken by individuals, but through vulvoscopic examination under a magnified view. So urethral before and after, stenosis before and after, and you could see the dramatic changes that ospemifene would have on the appearance and function of the vestibule. So a truly amazing breakthrough, and it's an oral pill. So people who don't like touching the area or putting things, creams and ointments in the vulva could benefit. The first ever FDA-approved drug for HSDD was in 2015. So there's an action of serotonin, traditionally an inhibitor, through the 5-HT2A receptor, increases glutamate, which acts to, it's a fight or flight sort of neurotransmitter, so it's against desire. And serotonin can act on the 5-HT1A receptor to the opposite. It decreases glutamate, which would increase desire. So flibanserin is an MSAA, multifunctional serotonergic antagonist and agonist, or agonist and antagonist. So it blocks this 2A, so it lowers the glutamate, and it activates this thing, which already lowers glutamate. So both lowering glutamate increase desire. So a very fabulous agent. On the left, you can see the FDA approval requirements, satisfying sexual events, female sexual function index and desire, female sexual distress scale, all statistically beneficial in the group that took flibanserin. That's in premenopausal women, a lot of good data for postmenopausal women also. Prasterone is one of my home run favorite agents on earth. Described by a Canadian, Fernand Labrie, who literally has 1,000 peer-reviewed publications. So, prasterone is DHEA, dehydroepiandrosterone, 19-carbon steroid that turns into androstenediol, androstenedione, testosterone, and dihydrotestosterone. Here are your 5 androgens. The androstenedione turns through aromatization to estrogen and estradiol. And this agent acts intracellularly, so it doesn't get into the bloodstream. It's intracrinologic, which is really safe, and therefore can be used in women who can't tolerate or take hormones due to oncologic problems. And here's a great slide. This is the thickness of a healthy vagina. This is after oophorectomy. This is after oophorectomy with DHEA. It turns back to the same thing. So DHEA has the ability to restore tissue integrity in the vagina. Now, this is cool. Oophorectomy, DHEA, and an agent that stops estrogen action. It's a blocker of the estrogen receptor. You still get the same improvement. So you could see the magic of DHEA. The androgens itself alone, forgetting the estrogen, can help. And then Sue and I did this fabulous prasterone trial, again, before and after vulvoscopy. We sort of do that a lot, just to make sure these agents work. Reminding you that prasterone is intravaginal. These are photographs of the vestibule. So you get a twofer with prasterone because the stuff oozes out of the vagina overnight and it fixes the vestibule. So it's really a ginormous home run agent for women with GSM. Bremelanotide is the next agent for HSDD. And bremelanotide is a melanocortin-stimulating agonist. It has melanocortin-stimulating hormone, MSH, is 13 amino acids. Bremelanotide is 7 amino acids. They sort of mimic each other, and when you give the injection, you get basically release of dopamine in the medial preoptic area. These are the statistical things that the FDA had to see. Now, bremelanotide is the first agent to be given to women in a placebo versus active drug crossover trial where the women went into an fMRI neuroimaging unit to see exactly where the thing worked versus control. Flibanserin never did that. This agent acts on parts of the brain that reduces self-consciousness, increases attention to sexual imagery, sensitizing women with HSD to erotic stimuli. It's a pretty amazing drug. We use now a lot in men off-label, by the way. SWISH had a consent process of care for PGAD, this just awful suicidal condition described by Sandy Lieberman in 2001. And this was a groundbreaking strategy to better understand and how to manage through regions PGAD. Then we get into the surgical benefits. In 2004, Bornstein did a surgery on women with vestibulodynia. He took women who had large vulvas, and he did a labiaplasty, and he was next to the vulva, so he took, or the vestibule, so he took a biopsy there, no mast cells, no nerves, and he did surgery on these women who had nerves and mast cells, and he basically defined 20 years ago the reason for the vestibulectomy surgery as defined here. And I don't know if you were around for Alyssa Yee's presentation on how we've refined the surgery. We only need to take 1 to 2 millimeters of tissue because all the pathology is just underneath the epithelium. A lot of clitoral problems. Gynecologists do not examine the clitoris. I know that's the craziest statement on earth, but gynecologists do not examine the clitoris. So there's clitoral pathology that needs to be addressed. Clitoral adhesions is the thing, and it's just a simple in-office lysis that we presented, and it's being done now universally for women. So the prepuce is attached to the glands, and the smegma that is normally released can't be released, so it collects in these white sort of pearl things, keratin pearls, and that's needs to be excised, all in the office. You don't have to go to the OR for that one at all. And my final sort of thing is the realization of the cauda as a remote area for genitopelvic dysesthesias. And these are just some of the slides that show that the three nerves, pelvic, pudendal, and sciatic, come together as a sacral nerve root, and that injury along their passageway from the cauda equina to the conus medullaris can be injured and cause symptoms. And here is Dr. Chol Kim doing surgery on that, and we have an algorithm that helps us define who's who for surgery. So I've just given you a 10-minute thing on 25 years. It really has been a passion and a joy and a love, and my favorite thing is to now see young people go to UC Irvine and now become the first faculty member doing female sexual medicine. So the take-home message is there's a lot of FSD, there's a lot of MSD being studied, but FSD is only minimally studied, practiced, researched, and taught in medical schools. That needs to change. ISSWISH is the place to make this happen. SMSNA is now integrating FSD within it, which is just amazing. There's a bright future and a dire need for practitioners to research FSD. And again, back to Yaffe, you don't know what you're missing until you bring this within your department. Thank you so much.
Thank you.